Hello. Today we're going to be talking about congenital heart disease and pulmonary hypertension, or at least the basics enough of what a general pediatric surgeon should know. It's not going to be in the same depth as those with advanced cardiology training. The usual disclaimer: no conflicts of interest, and this information was collected from just one person, although multiple training institutions in the summer of 2024, and you may have different experience or knowledge, which is also right. Let's get to it. One more disclaimer: this is just a foundation for the knowledge of congenital cardiac disease. It's not a comprehensive guide. The cardiac care of these infants and children can be remarkably complex. All right, a little checklist. If you're in the PedSurg Critical Care Fellowship, being able to draw the most common anomalies and recognize the implications, then go through the recommended reading. A lot of topics to cover. We were talking about the different types of congenital heart lesions, those that are called non-cyanotic and cyanotic, how that affects the general surgery patients, and what you might be asked to do in these populations, and then again about pulmonary hypertension and the consequences of that, particularly as it relates to perioperative risk in general surgery patients. Without further ado, we're going to get right into it with the non-cyanotic shunting cardiac disease. The first of these is septal defects, atrial and ventricular. Atrial septal defects in most patients results in a left to right shunt, and spontaneous closure is frequent in young patients with small defects. Larger defects often remain asymptomatic up to adulthood when they start to have fatigue, some exercise intolerance. Ventricular septal defects can be an isolated anomaly or a feature of a more complex malformation. Many patients with isolated defects, especially if small, can be asymptomatic, and those small defects often close spontaneously. A VSD can be classified as restrictive or non-restrictive, which is based on the size of the defect and how much blood flow occurs across it. In the restrictive case, usually a small amount. Non-restrictive usually for a larger defect and allowing a large amount of blood flow between the ventricles. In most patients, that results in a left to right shunt, which can cause pulmonary overcirculation, which is when there's abnormal amounts of blood to the pulmonary vasculature. In infants, that often results in failure to thrive, poor weight gains, poor feeding, especially PO feeding, and tachypnea. Other septal defects: atrioventricular septal defects, aka AV canal defects. And here's a picture of some of those. And you can see that the position of the septal defect affects how much blood is shunted through the atria versus the ventricles. Additionally, the position of the common AV junction can determine if this is a balanced or unbalanced defect. In most patients, the right and left sides to the common AV junction are comparable, and the ventricles are similarly sized. However, in a minority of 10% or less, one side is dominant with relative hypoplasia of the contralateral side, for example, in this case, unbalanced towards the left, or if it was balanced more towards this way, you would see hypoplasia of the left side. The medical management of the congestive heart failure with diuretics and vasodilators like captopril. It will be common feeding difficulties, failure to thrive. Surgical treatment of a balanced defect, usually within the first few months of life, closing all the septal defects and repairing the atrioventricular valve. Unbalanced is a little more challenging, depending on how hypoplastic the contralateral chamber is. Single ventricle palliation may have to be considered, and we'll talk more about that when we talk about hypoplastic left heart syndrome. Prognosis for this: unrepaired, poor survival beyond 5 years, but patients who survive the surgery have pretty good survival, over 80% at 10 years. All right, and this one's persistent patent arteriosis, which is in the non-cyanotic, although it can cause some cyanosis. Primary isolated PDA, ductus usually constricts and closes within the first day of life, and then permanently becomes the ligamentum arteriosum over the course of several months. Beyond day of life 4, the incidence of PDA increases with the prematurity of the infant, with over half of infants weighing less than 1 kilo, the extremely low birth weight infants having a persistent patent ductus arteriosus. The presentation will depend on the ductal size. The degree of shunting can range from completely asymptomatic to some of those symptoms of pulmonary overcirculation. Again, tachypnea with feeds, frank respiratory distress, necrotizer enterocolitis can be responsible for recurrent episodes of that. Intraventricular hemorrhage, pulmonary edema, and hemorrhage. Management can be watchful waiting in select infants with some fluid restriction. We try to avoid diuretic use in preterm infants due to their somewhat precarious fluid balance state and immature kidneys. Options: if the PDA fails to close with observation, or if it is a hemodynamically significant PDA and closure is indicated. Up to 70% success rates with a medical closure, which is most commonly nowadays with acetaminophen, although more historically classically with indomethacin or other NSAIDs. This can be done in up to 3 courses. The PDA can reopen even if it's documented closed after a medical closure. There are catheter techniques. Those catheter techniques are reported to infants as low as the lowest I've seen was 478 grams, so super tiny babies, not necessarily excluded from that option, depending on the institution and cardiology, radiology, cardiac surgery practices. And then there's surgical closure, which can be done open or thoracoscopically. There is around a 3 to 5% rate of recurrent laryngeal nerve injury, as that wraps around close to that PDA. And that's to be suspected if there's feeding issues or stridor postoperatively. PDA can also be present as a necessary component of survival in ductal-dependent congenital heart disease in cases of RVOT, right ventricular outflow tract obstruction, such as pulmonary atresia or stenosis, or severe tetralogy of Fallot, hypoplastic right ventricle tricuspid atresia. The pulmonary flow may be dependent on the patency of a ductus arteriosus. And in hypoplastic left heart syndrome or intubated aortic arch or severe coarct, the systemic flow may be dependent on the patency of a ductus arteriosus. And if these conditions are known, Tylenol NSAIDs are contraindicated and a prostaglandin infusion may be started to maintain patency. If they're unknown, there can be quite a dramatic presentation when the duct starts to close, with sudden decompensation of babies either in the NICU or sometimes even at home. Consequences of the non-synovial shunting disease. We've talked about some of these already. Left to right shunting, pulmonary overcirculation, which again is abnormally high blood flow going across the pulmonary vasculature, leading to tachypnea, persistent oxygen requirements, poor PO feeding, failure to thrive, slow weight gain, pulmonary edema. And then Eisenmenger syndrome, which is the severe consequence of a large unrepaired left to right shunt, including ASD, VSD, PDA. It's progressive pulmonary hypertension with a rise in PVR that eventually turns the shunt bidirectional, and with further worsening right to left, resulting in systemic desaturation, and survival once that sets in is rather poor, 50 to 60% survival over 10 years. Moving from non-cyanotic shunting defects to obstructive defects, so here we have right ventricular outflow obstruction, including pulmonic stenosis or pulmonary valve stenosis. There can also be sub or supravalvular obstructions, for example, pulmonary artery stenosis. Mild to moderate cases may be asymptomatic until later childhood when they have dyspnea exertion. In severe cases, there may be life-threatening obstruction due to inadequate pulmonary blood flow. Left ventricular outflow obstruction, such as aortic valve stenosis, hypoplastic arch, aortic coarctation of the aorta. And on the bottom right picture here, we see a hypoplastic aortic arch with systemic blood flow being dependent on the PDA and a repair going through for that particular lesion. The timing and repair of the RVOT, LVOT obstruction depends on the severity of the condition. There are both catheter and open surgical options depending on exactly the anatomy. For ductal dependent disease, PGE1 prostaglandin infusion will be started. Unrepaired coarct has long-term complications including hypertension, coronary disease, with death occurring at a median of 35 years of age. Moving on to our cyanotic lesions, tetralogy of Fallot, the most common form of cyanotic congenital heart disease. There is a genetic association with 22q11 The four components are a ventricular septal defect, overriding aorta, right ventricular outflow obstruction, and right ventricular hypertrophy. Typically, infants undergo repair around 3 to 6 months of life unless there's severe cyanosis. With modern management, almost all can reach adult life. The repair consists of closing the ventricular septal defect, widening of the right ventricular outflow obstruction, repair or replacement of the pulmonary valve, and possibly some widening of the pulmonary artery. Prior to repair, they may be prone to these things called TET spells, which are these cyanotic episodes caused by increased right to left shunting through the VSD, can be brought on by crying, feeding, agitation, and can be turned into a cycle sometimes, as the decreased PaO2 can lead to desire for more rapid breathing, which can cause more negative intrathoracic pressures and increase the venous return, which increases the amount of shunting. Treatment can be through squatting, oxygen, sometimes beta blockers, depending on how severe those are. Next, cyanotic heart lesion, double outlet right ventricle, and as you can see, the pulmonary artery and the aorta are both in the right ventricular outflow, and depending on the unbalanced nature, the timing and type of surgical correction is variable. The goal is to establish continuity of the left ventricle to the systemic flow and the continuity of the right ventricle to the pulmonary flow, and close the VSD. Multiple different options for that. However, if the left ventricle is terribly hypoplastic, you may end up with a central ventricle or Fontan physiology, which we'll talk about upcoming. Transposition of the great vessels, in this case the aorta is coming from the right ventricle and the pulmonary artery is from the left. Postnatal management, prostaglandins, because this is a dental dependent lesion, oxygenation, correction of acidosis, possible balloon atrial septostomy to cause more shunting. Again, the timing and type of surgical correction depends on the exact anatomy. Options include, not limited to, the atrial switch, which ends up leaving the RV pumping systemic circulation, arterial switch, which results in each ventricle pumping to its proper exit. Atrial dysrhythmias can be common with this. Hypoplastic left heart, another cyanotic heart lesion, underdevelopment of the LV such that it is unable to support systemic circulation. Without intervention in the first few days of life, it's fatal, and in some cases collapse or even die due to closure of the duct. Spectrum of presentation at birth. Babies that have open shunts may appear initially well before developing CHF, respiratory failure, pulmonary recirculation symptoms as that shunt or PDA is closing. Infants with a restricted shunt or restricted atrial shunt may be cyanosed from birth. Infants with aortic coarctation may resemble other neonates with dental-dependent LV outflow obstruction. You can see in this case, picture to the right, the RV is responsible for both pulmonary arterial flow and systemic flow. Around 65% 5-year survival, 55% 10-year survival for this. Postnatal management is to secure ductal patency with a prostaglandin infusion, diuretic or RV inotropic support, and intubation. Options are comfort care, neonatal primary transplant, or stage single ventricle palliation, which is probably what we see more frequently. And that includes the stage 1 or Norwood, which is done as a neonate, the stage 2 or Glenn, which is done at 6 to 18 months of life, and the stage 3 in Fontan, which is done usually around age 4 or so. The effects of ventricle palliation and the perioperative knowledge that you need to know about and from a general surgery standpoint will be discussed on the following slides. Here is a brief table. One thing to know when you're seeing these babies is the expected peripheral arterial saturation will be different depending on what repair they've undergone. And you can see that following the Norwood, it'll be reduced in the 70s to 80s and becoming higher with each subsequent surgery. Stage 1, what's referred to as the Norwood. The procedure is to remove the atrial septum, disconnect the main pulmonary artery from the right ventricle, and reconstruct the aortic arch so that it is the exit of the right ventricle. And then you'll obviously need to get pulmonary blood flow back from somewhere, so it's put either to systemic circulation, which is a Blalock-Taussig shunt, or to the right ventricle, which is a Sano shunt. The goal is a primarily balanced one-to-one pulmonary to systemic blood flow circulation. Postoperatively, the importance of achieving balance with systemic saturations of about 80%. And if you see that 80% and you're like, oh, they need oxygen, we can put them on some more, that can lower pulmonary vascular resistance, leading to volume loading the pulmonary's over circulation and cardiac failure with reduced systemic blood flow. So there's been a shift to manipulating the systemic rather than the pulmonary vascular resistance to maintain that balance. Following stabilization from this repair, they'll be transitioned to a surveillance period, usually on some form of anticoagulation or antiplatelet therapy to keep that shunt open, and usually a diuretic as well. Around 4 to 6 months of age, after allowing the pulmonary vascular resistance to normalize such that blood supply to the pulmonary artery no longer requires high blood pressure, the Glenn procedure will be performed, which is removing the shunt and disconnecting the SVC from the heart and returning it to the pulmonary arteries, such that flow into the pulmonary arteries is now largely passive. This results in a more robust child and anastomosis that grows with the patient. There's generally a little mortality in between stages 2 and 3. When the IVC return becomes more substantial, and remember from our ECMO talk we talked about for bicaval cannulas, the IVC having relatively little contribution, especially in younger children who aren't yet walking. But when that becomes more substantial, as the child grows older, the degree of desaturation can become more severe, and at that point, it's time to transition to a stage 3 Fontan. Picture on the right here is the reconstructed anatomy with blood flow from the SVC going right into the PA, and the RV pumping other flow into the aorta. All right, the last step is the stage 3 or Fontan, which is done between 18 months and 5 years, usually around 4 years. The IVC is now disconnected from the heart along with the previous SVC. It now all drains into the PA in a passive fashion with total cavopulmonary return. This creates what's called the Fontan physiology. There's some anesthetic critical care perioperative considerations which are critical for those undergoing non-cardiac surgery. Pre-op, it's important to identify failing Fontan physiology, poor functional capacity, hypoxia, need for pulmonary vasodilator therapy, protein losing enteropathy, etc., and look out for what kind of antiplatelet or anticoagulation agents they may be on and how that might affect your surgery. Peri-op, consider the need for SBE prophylaxis, central venous pressure monitoring, and the transpulmonary gradient, which is the difference between mean pulmonary arterial pressure and pulmonary capillary wedge, and is used to monitor pulmonary vascular resistance, pulmonary hypertension. The goal is to maintain cardiac output, maintain preload, minimize pulmonary vascular resistance, and preserve ventricular function. So intra-abdominal pressures during laparoscopy can reduce venous return and cardiac output. CO2 can cause hypercapnia acidosis, which can also increase the PVR as well. And since there's no ventricle pumping into the pulmonary vascular resistance, that can cause problems. Truncus arteriosus, there is a common pulmonary artery and aortic outflow tract. The surgical repair is to close the VSD and create a separate valved outflow for each ventricle. This is done as early as possible, usually within the first days or weeks of life, to prevent complications of pulmonary overcirculation and heart failure. And here we have one repair option called the Rastelli. Total anomalous pulmonary venous return and partial pulmonary venous return. The pulmonary veins in this case do not connect to the left atrium, instead returning oxygenated blood to somewhere on the right side, whether that's the supracardiac location, or such as the SVC, cardiac location such as the right atrium, or infracardiac such as the IVC. Surgery for this is generally done as an infant. The timing and type again will depend on the exact anatomy. It can be needed sooner if there is pulmonary venous obstruction. Blood flow may rely on an ASD, and if that's restrictive, they may need a balloon atrial septostomy preoperatively. Other implications in the setting of congenital heart disease for pediatric surgical critical care. If you're at an institution where you might be responsible for vascular access, keep in mind that the usual IJ access may not be possible, and you also may need to preserve femoral access for catheterization. So just talk to the cardiac surgeons and see which veins they may be open to using. These babies often have failure to thrive, slow weight gain, poor PO feeding, and require G-tubes. Laparoscopy has been shown to be safe without increased risk of complications. They may be more prone to dental ischemia, other GI complications due to impaired regional perfusion, and then it may also be called for incidental finding of malrotation in infants with heterotaxy. And here's an visual abstract where there's 40 to 90% rate of malrotation or intestinal rotation abnormalities in patients with heterotaxy. However, this don't seem to have the same risk of volvulus, but they do have higher rates of both small bowel obstruction and mortality from the surgery from a LADS procedure. And so the recommendation is currently not to screen asymptomatic patients with heterotaxy. And if you do end up getting a study showing malrotation, if they're asymptomatic, to wait until cardiac palliation procedures have been performed to perform that LADS procedure. Moving on to pulmonary hypertension, we'll go over types and terminology, including persistent pulmonary hypertension, pulmonary hypertension associated with bronchopulmonary dysplasia and congenital heart disease, and when and how you might be involved and what you should know. Pulmonary hypertension, the first type terminology that we're going to talk about, persistent pulmonary hypertension of the newborn, or PPHN. This occurs in 1 to 2 of every 1,000 births. It's a failure of the pulmonary vascular resistance to fall after birth, and this can be caused by a number of things: acidosis or hypoxia from lung parenchymal disease, such as meconium aspiration, pneumonia, or respiratory distress syndrome. There can be idiopathic abnormalities of the pulmonary vascular bed, or in the setting of pulmonary hyperplasia, such as in CDH or renal agenesis, and those carry the highest mortality. The presentation will be a poorly perfused and cyanotic infant after delivery with a high pre- and post-ductal gradient, which is the difference in oxygen saturation measured in the right upper extremity versus one of the lower extremities. The left upper extremity is unreliably classified into pre- or post-ductal. That can be dependent on the exact anatomy. Treatment: supplemental oxygen, rule out sepsis, congenital heart disease, start INO, prostaglandins, can consider ECMO, which has good results in this population, maintain a normal temperature and vascular volume. Pulmonary hypertension associated with BPD and chronic lung disease, which results in a contraction of the vascular bed causing pulmonary hypertension, is another type. It can also be associated with congenital heart diseases, either causing pulmonary hypertension, such as pulmonary vein stenosis, or mimicking a pulmonary hypertension presentation, in which case, if cyanotic heart disease is remaining on the differential, maintaining the PDA with prostaglandin infusion is considered safe while you're still trying to figure things out. Recommendations for treatment: pulmonary vasodilators, INO, sildenafil, and you'll see other options here: high frequency ventilation, surfactant administration, and cannulation for ECMO support. Perioperative considerations: hypoxemia, hypercarbia, pain and agitation. Acidosis can elevate the PA pressure and cause a pulmonary hypertensive crisis. This can lead to dysrhythmias, low cardiac output, worsened systemic and coronary perfusion. The goal is to maintain perfusion and avoid triggers that can increase the pulmonary vascular resistance. And you can see a couple different paths here on this bottom right picture, where you get increased pulmonary pressure, and then you form this cycle, which can lead you into a crisis of pulmonary hypertension. Some other recommended reading and a little quiz. A 3-month-old X27-weeker treated with acetaminophen for PDA had documented closure on echo, is now being treated for a second episode of abdominal distension and cut blood in the stool after trialing feeds. Distal investigation for recurrent neck should include echocardiogram to look for the PDA, which was previously documented as closed, carcinoma, SRB, or a change in diet. And say the correct answer is this. What I really wanted just to say was, with this question, was that you keep in mind that a duct can reopen over time, and even if it's documented as closed, doesn't mean that it will necessarily stay that way. And if you're having symptoms that could be consistent with a opened PDA, go ahead and look for that. Management with the CDH is returned to the NICU post-repair. Analgesia and sedation are being weaned. The baby now appears uncomfortable, and there's dropping perfusion. The most likely etiology is, and this is something we just talked about, agitation, inadequate pain control leading to a pulmonary hypertensive crisis. All right, and that concludes this little topic. We'll see you next time.